Welcome back to Jay's Smokehouse and our Cannabis Education Podcast. I'm joined by some magnificent guests. I've been excited about this so much. Medical Cannabis and Autism Spectrum Disorder. This is the panel that we're going over today. First, we have Dr. Bonni Goldstein, MD. She has published studies on medical cannabis treatment of ASD. She is also the author of Cannabis is Medicine. And all of this will be sourced in the description below, including our other guests. Next, we have Dr. Ruth Fisher, PhD. She has published articles also with the ASD and the Endocannabinoid System. She is also the author of the Medical Cannabis Primer. They're also sourced in the description, which I've already said. Last, but certainly not least, we have Professor Janna Champagne, a retired nurse. She had published articles as well. And I see that she has a success story with her own daughter with medical cannabis and autism spectrum disorder. So I'm really excited to talk to her about that. And she also is an award-winning medical cannabis formulator. And again, all this is sourced in the description. Now, I would like for you guys to introduce yourselves, please. Dr. Goldstein, please.
So my name's Bonni Goldstein. I trained as a pediatrician over 30 years ago here in Los Angeles. And after working in pediatric emergency medicine for about 13, 14 years, I was quite burned out and took a little time off. And during that time, someone asked me about cannabis, a close friend who was struggling with a serious illness. I'm embarrassed to say I didn't know anything. And I started reading about it and studying it and saw her get some really important benefits for the quality of her life and started working in the field and haven't looked back since. Since I've been doing this since 2008, I've seen over 18,000 patients. Started seeing pediatric patients in 2013. And take care of a lot of kids with epilepsy, autism, cancer, and other serious conditions.
I can't wait to get into this later. Dr. Ruth Fisher, why don't you go ahead?
I'm an economist by training. I have no formal medical training, but I've spent many years in the healthcare industry doing research. My dad was a private practice physician, and I've always had a very warm spot in my heart for the industry. And in my professional career, I spent a lot of time with biotech companies and startups in the healthcare industry and just done a lot of research. About 2015, my brother was diagnosed with multiple sclerosis. And one of his doctors said, I think he had tremendous multifaceted neuropathic pain and he had tried everything. And at one point, one of his doctors finally said, a neurologist said, I think you might be able to benefit from medical cannabis, but I can't give you any guidance. So he was happy to have something new to try. And he started playing around and experimenting on his own. And I didn't know any of this until he came to me at some point and he said, I'm using medical cannabis. And I'm like, really? And he said, and it's actually working. And I'm like, really? And he said, but I'm not getting great effects. I think that if I knew what I was doing, I'd be getting better benefits. He said, can you help me figure this out? So at that point, I knew literally nothing about cannabis. I was very touched by the stigma. I had used it recreationally long ago and far away. I said, I'm just going to set aside any priors I might have and just try and figure this out. And so I jumped into the research and fell down the rabbit hole very quickly. My brother and I, at some point, my brother's like, he's like, so I'm reading the literature and kind of understanding, giving him pointers, and it's working. And he said, we need to create a technology that helps other people do this better than we're doing it. And so we designed a tracking technology, and you see some of them out there now. We never released it because there's a difficulty in getting the COAs, the certificates of analysis that tell you what's in the product. And if you don't know what's in the product, it's very difficult to track use, as I'm sure everyone here is aware of. But in the meantime, we had amassed so much information and it was very well compiled and collated that we decided to release it in a book. So that's kind of how the book came to be. And ever since then, I've been an avid researcher and advocate for medical cannabis. I will say that once I learned about the endocannabinoid system, what I felt is a profound sense of sadness that for so long people have been kept from this medicine for, purely political reasons. And so I just wanted to do my part to increase the information and promote good cannabis for all those medical potential users, actual and potential users out there.
I thank you so much. And that's awesome story. I can relate to a little bit of that, but there's so much more that I can't. And it's really interesting. Janna, please, I can't wait to hear about you and the success story with your own daughter.
Of course. And so, so my introduction to cannabis as medicine, after being a recreational user earlier in life, I grew up just south of Humboldt, California. And it actually replaced alcohol for me in my 20s, which I think was a really good shift, even though at the time I didn't realize I came from a long line of alcoholics. So it probably spared me that path. But I had quit cannabis. I had gotten into motherhood and went to nursing school, and, it was very frowned upon, and we were drug tested. And so it was just something I had to kind of put aside and didn't think too much about it until I got really sick in 2012. And I had a complete health collapse. It has to do with my extracellular matrix being dysfunctional, and it's really complicated. But one of my diagnoses was lupus, and I was having a lot of chronic pain with my symptoms. I was labeled totally and completely disabled in 2013 because of the severity of my presentation. And I sought cannabis just for pain relief. As a nurse, I was very motivated not to start down the opioid pathway for chronic pain management because I had seen what happens to patients that go that route. And a friend of mine was a grower, and he said, "Hey, why don't I'll give you some of my trim and make some medicine and try this and see if it works." And there were a lot of really fortunate factors in all of that, including that the strain he was growing was White Widow, which is renowned for pain management. And, my husband made me some good old RSO, and, I just kind of went at it on my own thinking, hey, what can it hurt? It's a plant, it's safe. Well, the cannabis not only managed my pain and helped me be more and more functional as the days went on, but within about 6 months of starting cannabis, my lupus labs actually seroconverted, and I became negative for lupus as a diagnosis. So as a nurse, that really got my attention. Like, wow, this plant can do things that pharmaceuticals can't touch. I was able to wean off my pharmaceuticals that I was using for lupus, which was prednisone, using THCA, which is also very anti-inflammatory, and off of the Plaquenil using THC. And so it actually reduced my reliance on pharmaceuticals as well. So that's what really made me start deep diving into the research, trying to understand how I could be experiencing these benefits of a plant that I had never been taught about in nursing school. Like they hadn't even touched the subject in nursing school of the endocannabinoid system. And so I was pretty comfortable when when my daughter with autism entered a behavioral crisis with puberty onset a couple of years into my own medicating with cannabis. And she presented with really extreme behaviors. She was self-injuring. She was aggressing and hitting all of her caregivers and parents. She was self-injuring. I mean, very, very severe. She would have, 2 to 3 hour long meltdowns where we could just do nothing to console her. It was pretty torturous. And so I went online again and I kind of compared her options with the mental health pharmaceuticals, the antipsychotics and the antidepressants and anxiolytics that they wanted to put her on, compared with the cannabis and what it could do for her without all of those horrible side effects like the extrapyramidal symptoms, which is involuntary bodily movements, without the risks that were actually life-threatening, like suicidal ideation and NMS, neuroleptic malignant syndrome, and Stevens-Johnson syndrome. Those are all known side effects of these medications that they use to treat autism. Where cannabis, safe and effective use over 5,000 years in humans, and not a single death or bad. The side effects are actually beneficial, and people seek the plant just for the side effects because they're so pleasurable. And so to me, it was kind of a no-brainer. And we started her on cannabis therapy. It alleviated her crisis completely. It alleviated this edge my family was on, and it actually spared her out-of-home placement for safety reasons. So just added to my passion for this plant. In 2017, I wrote her story, and I did publish on the cover of a magazine. This is Everything Medical Marijuana magazine. It sold in Barnes & Noble nationwide, and I jokingly call this my coming out of the cannabis closet moment, where I declared myself as a nurse, a patient, and a mom medicating my teen daughter with autism with cannabis. And so that, that's kind of been our journey. My daughter is now 21 years of age. She went from being labeled mentally retarded from her school district. Her public school experience was pretty atrocious. They didn't see her intelligence. And they tried to put her in a classroom that basically had no academic in second grade. She went from that to graduating high school in 2021 with a diploma. So she's really progressed beautifully. Her speech that emerged around age 10 really has improved greatly, and she's now able to verbally communicate with us, not to mention that her quality of life and just her experience as a human has benefited so greatly from cannabis. One of our frustrations now is that she's ready to be more independent of parental care, but there are zero options for licensed care homes that will accommodate her cannabis therapy. So that's kind of what spawned my involvement with launching 501c3 Autism Safe Haven, for which Bonni Goldstein is on our medical advisory board. And we are committed to creating cannabis inclusive healthcare options for those with autism to help include that cannabis in their caregiving and ensure that they have the benefit of that rather than having to revert back to pharmaceuticals in order to live in a licensed care home. So sorry, that was too long.
No, that's amazing. It was a little long, but it deservedly so. Thank you so much. That's such an amazing story, and it's something that people really need to hear. That's the whole reason I decided to have this panel podcast. Was I really wanted to get the information out, and I wanted, I didn't want to say it because most people see me as an idiot on here, so I really wanted to have some people who obviously are not, who can be seen as titans in the medical cannabis community, in my opinion. And so I'm very thankful that you guys came on here. Now, the first one is, and I'd like for all of you to respond, and we'll just go in the same order we've been going in. Why medical cannabis? Why is it supposed to work? And if so, are there any cannabis profiles that work best for ASD, or autism spectrum disorder? And then I have a follow-up question after.
All right. So going in order, I'll start. So why does it work? So we all have a system called the endocannabinoid system that's been mentioned. This is not an isolated system. It's a system that crosses over everywhere, right? So we have it in our brain, in our gut, in our connective tissue, in our liver, in our pancreas, and so on. It's one of the most widespread receptor system. And it's basically made up of receptors, which sit on cell walls. And receptors are like, there you go, receptors are like locks. And then we make a key that fits in the lock. So the same way we have serotonin receptors and we make serotonin to bind to the receptor to deliver a message, we have cannabinoid receptors and we make endocannabinoids, endo within cannabinoid-like compounds. And it just so happens that there's this plant out there called the cannabis plant that makes phytocannabinoids, PHYTO, that interact with this system, but not only the endocannabinoid system, but other what we call non-cannabinoid receptors and enzymes and so on. So it's this very widespread system. And we have to remember that it's existed for a very, very long time, and it has been documented that it's been around for millions of years and was in our very simple, like sea squirts and Hydra vulgaris, these very simple creatures. And the reason that the endocannabinoid system developed was in basically a survival mechanism in response to environmental or internal stressors. So think about, I like to use that that clown blow up doll. It's probably dating myself here, but you punch the clown and it kind of tips over and pops back up. Okay, your endocannabinoid system is supposed to help you kind of stay upright and stay functioning, so to speak. And it's just very important. And when you have a problem in your endocannabinoid system, other medications, for the most part, do not target the imbalance in that system. And so, why would I take 37 other drugs for a symptom when I can take the compound that targets the system that might be not working very well? It just doesn't make any sense to me to use lots of other compounds when you can target the actual root cause of illness. And I will share with you, so there are 2 studies out now, 2018, the first study from Stanford, and 2019, a study from Israel that showed that children with autism have lower levels of their endocannabinoids. And so to me, that's an endocannabinoid deficiency. Why would I not replace those cannabinoids, especially safely under medical supervision? And it may not work for everyone, but my point always has been that, especially under medical supervision, tremendously safe medication.
Thank you so much, and couldn't agree more. Dr. Fisher.
I would add, so I think the studies that I was going to cite are the same ones that you mentioned. I was fascinated to learn that, as Dr. Goldstein mentioned, the receptors in our body, that one of the studies shows that people with autism actually have fewer of those receptors, meaning their system is deficient. And she also talked about the endocannabinoids that are produced by our body that, activate those receptors. And the other studies showed that there are lower levels of those endocannabinoids in our system, so that they're less able to activate receptors. And so, and this is in patients with autism. What's also very interesting to me is when you look at, Dr. Goldstein described all the different systems in our body where the endocannabinoid system plays a role. And if you look at patients with autism, it's amazing how they have deficiencies or problems in pretty much all of the different systems that the endocannabinoid system is charged with overseeing. So it's not a coincidence, I think, that children with autism or adults with autism experience the problems they do. All of this would suggest that the underlying problem here is with the endocannabinoid system.
That's what I've seen with the studies that I've been reading as well. Janna?
Yes, and that, you guys have covered quite a lot already, but I agree with all of the above, and I would add that it's, and I've kind of already alluded to this, but when you compare all of the options for a child with autism that's suffering and even in crisis and having trouble managing, and the whole family is impacted by that, it's important to really assess the risk versus benefit of all of those options. And I think when we do that as medical professionals in an objective assessment, it becomes really clear that cannabis is the least risky. There are some considerations around THC in childhood and adolescence that should be considered, and we should always be screening any pharmaceuticals they're taking for interactions. But aside from those considerations, and schizophrenia and the family is another one, with medical professional that's competent, they can guide through some of those risk factors, and it ends up being the least risky and potentially the most beneficial because it is filling these known deficiencies in autism, like Dr. Fisher mentioned as well. And I do have an article on my website, which is jannachampagne.com. It's just like my name. And it's called Cannabis for Autism Harm Reduction. And it really digs deep into that comparison. And I have research cited that actually reflects that the endocannabinoid system can balance some of these major systems that are defunct in autism. And the primary ones I've worked with patients are, gut balancing, neurological balancing, and immune system balancing. Those seem to be the major systems that are impacted by autism. And then I know you asked about the formulation, so I'm happy to address that piece. For patients in general, I tend to refer them to whole plant cannabis formulations, which only constitute about 5 to 10% of what's on the market for retail cannabis sales. So they can be a little bit difficult to find, but it can literally make or break outcomes for certain patients. And so it is very important. And my nurses and I actually came up and coined the flow criteria to help patients understand what to seek when they walk into that dispensary or Google a product. And it's flower-derived, lab-tested, organic, and whole plant spectrum. Whole plant meaning it's been processed in a way that concentrates the flower as nature intended as closely as possible. I think some loss is inevitable, but they can use lower heat and longer processing time and things like that to really try to keep that profile as it was in nature. And I think there's a lot of synergy with those more than 500 compounds that are found in the flower, where a lot of processing of cannabis products ends up removing and stripping away many of those compounds. And, an example would be like CO2 processing is normally a couple of dozen compounds in the final product. Isolate and distillate is one compound. And what the research reflects is that they work very differently in the body. And the whole plant is supported by research for working much better at a fraction of the dose, 25 to 30% of the dose, with fewer side effects and more predictable dosing thresholds. So what we see in isolates is that they exert a bell curve response in the body. So as you increase the dose, it peaks and actually drops off and stops working. So you think about these patients with cancer and autoimmune that are taking pretty intensive dosing, 75 to 100 milligrams a day is pretty standard for those conditions. And if they're using the wrong product, they could be on the right side of that bell curve and paying a whole lot of money to get little to no benefit from that cannabis therapy. So it is really vital. And then as far as the compounds that seem to work best for those with autism, I tend to recommend the indica strains of cannabis or indica profiles, meaning that the terpenes are those that tend to be more calming and sedative in nature. As far as, I know Dr. Bonni and I were just speaking the other day, and she was telling me about all these benefits she's seeing with CBDV and autism and seizures. So just, as far as which compounds we choose for a child, that really is more of an individual approach where we do an assessment. We ask what are the priorities for that child, what are the symptoms that parent would like to see managed better, and kind of address it that way. THC is often of benefit because that's what's going to most closely replicate the anandamide deficiency that we find in autism. But THCA is another one I've seen huge benefit for, any of the acids and that anti-inflammatory effect, because autism is also connected with systemic inflammation and brain inflammation. If they're having gut problems, that might be more like the CBD or the CBG. And there's considerations around all of these different compounds that really should be assessed by a medical professional that's knowledgeable to put together. It might even just be our best guess. It might not be the final regimen they end up on that is their sweet spot, but we can better tell parents where to start and then stay in touch with them as they switch it up and try different things and report back. And through that process, we can usually get them a protocol that can bring a lot of benefits to their child and their family. So that's kind of the approach I've used in the past.
Thank you so much. I've never had someone explain it that well, or give any kind of guidance on the on cannabis profiles. And to add to that, I didn't think I was going to be able to add tonight, but I am a prior extraction manager, and I just wanted to add to the terpene or the whole plant, like Janna was saying, was just extracting. You lose so much. Ethanol extraction is what I specialize in. That's what I would always suggest if anybody's going to do it, as you retain as much as possible. Mm-hmm. But the thing that kills me is doing like a distillation or a CO2, and they say, we'll just re-administer the terpene profile it has. And I just sitting there going, it only has 3 at most. And that's not all the terpenes that are in a strain. There's so many different minute terpenes that will still affect it in some way, at least in my own theory or hypothesis. And so that's the one thing I try to tell people is, you can reintroduce those 3 main terpenes that they have identified, but there's so much more to that terpene profile that you're not getting back.
Well, and the whole plant profile. There's the antioxidants, the bioflavonoids, the essential fatty acids, the chlorophyll. All of those have health benefits that are evidence-based. And then there's a synergy with all those compounds that we simply can't replicate with stripped down compounds.
But THC is the only one that matters, right?
No, I disagree.
I do too, but that's what I hear every time I'm talking to somebody. Oh,
but there is a theory, and it's actually been substantiated, that all cannabis use is medical. They are self-medicating something if they're using cannabis. And it benefits whether they're, in their mind, they're thinking medical or recreational. And Dr. David Allen spoke about this in a retrospective study they did on patients that had been smoking cannabis for 20 years. They weren't thinking medical, they were thinking recreational. And in that retrospective study, they compared cannabis smokers of 20 years with cannabis non-smokers of 20 years, and there was an 80% less instance of diabetes in the smokers.
Well, just take, you guys answer this, because I'm going to pose this more as a question, but it just take like alcohol. I can't see any medical benefit to alcohol, yet somebody who has one drink a day is a lot more healthier in the mind than someone who doesn't drink or someone who drinks excessively. And so I've seen psychologists suggest that that's
not true anymore.
Oh, it's not? Okay.
No, the latest research shows there is no amount of alcohol that's safe for human use. We don't have a receptor system for alcohol, right? We have, remember, the phytocannabinoids mimic compounds that we make, and we make those compounds for a reason. Right. And if you don't make those compounds, just like people who don't make insulin need an external source of insulin because their sugar is out of control, type 1 diabetes, we clearly understand that. Low thyroid, we can replace with thyroid medicine. Some people can heal their thyroids without that. But in general, when you have a deficiency, there can be disease, right? Disease and conditions related to that. And there is no equivalency with alcohol. I want to make that clear. And I think Dr. Fisher and I were talking before we started the podcast, which is that there is this kind of cannabis was taken away from us, with this political nonsense, right, back in the 1930s and 40s. And when I think about all the disease that has resulted over the last 80 years, that maybe could have been prevented, all the suffering, all the unnecessary suffering that could have been alleviated. And remember that when it was taken away from us, as a community, nobody knew what a cannabinoid was. Nobody knew that we had an endocannabinoid system. So I think looking at it with fresh eyes is what we need, and to still propagate the whole reefer madness idea, right, it's just not a way to go. It's detrimental. And when I think about families who are suffering with children with autism, where they can't leave their house, they don't sleep at night, they have to hide everything in the house or it might get broken or ruined. Why would anybody want to withhold medication that, again, safe, that might work? I'm not guaranteeing that it will work, but why wouldn't you offer that? Isn't that the compassionate thing to do, especially now that we have an understanding of the science?
Oh, completely agree. And actually, my point with the alcohol was because there is no, I want to make that clear, there is no medicinal properties whatsoever. What they say is it's the stress relieving of just being able to relax during the day. It has nothing to do with the alcohol. And that's one thing you can benefit from cannabis and not have the poison that comes into your body. But that was my point, was let's go with the cannabis that can actually give you more benefits than the alcohol that's poison.
Yeah, there's a lot better choices. Cannabis, exercise, yoga, meditation, spending time with your family and friends. There's a lot. I think the list above alcohol, there's a lot more things up there.
I think a point that I would like to echo that Dr. Goldstein made earlier is that according to the traditional healthcare community, people aren't supposed to enjoy their medicine. And I think that, when people think about what's therapeutic or medicinal, they're not thinking about actually enjoying taking it. And I think that that's a real big psychological barrier for a lot of people.
And that's actually something we'll get into with another question, is the THC levels of what you do as a take as a medicine. But the next question is really something I've had a lot of people ask me, and it's something I wanted to know as well. And I've noticed it in all of your articles and studies. And that is, why are there so few girls in ASD studies? And is it true that they are more difficult to diagnose?
Well, the incidence of autism is 4 times more, it's 4 times more prevalent in males than females. I don't know that anybody knows exactly why that is happening. In terms of diagnosing, I think in general, diagnosing is somewhat difficult because it is subjective diagnosis. Interestingly, and I know you're going to get to my research, but the research that I've done on salivary biomarkers in children with autism to measure the impact of medical cannabis, we only had, I think, 2 girls in our small study. But what we found was that, and this is reflected in another study as well, is that it seems that boys seem to respond better to cannabis, although I have plenty of female patients that respond. I think that we don't really know yet why some people respond to cannabis and others don't. You have to remember that in the animal research, after they kind of a study is done, the scientists can, for good or bad, I mean, it depends on how you look at it, can sacrifice the animal and look at slices of their brain, right? You can look to see what's going on. So we don't have that technology in humans, right? We get to dive into your brain and look. Here and there, we can look at spinal fluid in certain studies that's been done with patients with schizophrenia and some patients with temporal lobe epilepsy, and even I think in fibromyalgia where they've looked at spinal fluid. But it's very hard to kind of understand the underlying endocannabinoid system, what we call the tone or the status. It's really a clinical diagnosis, and it's very difficult. Going back to my salivary biomarker studies, we did find a compound that was not an endocannabinoid, but a lipid-based compound that appeared in children with autism that did not appear in our control group. And so it's quite possible that that particular compound may be a diagnostic biomarker for autism. But as of yet, we really don't have any clinical, or I should say, objective way to diagnose children with autism. So it's still somewhat subjective. You know, there's questionnaires and you can observe a child. But remember, when you're seeing a child in a window, they may not show some of the clinical manifestations of autism. So I just think we're still, and remember, we call it an autism spectrum disorder, right? Because there's a very wide heterogeneous way that patients present. And so, and I want to just make one other mention. If you look at the study, the first study we published on the salivary biomarkers, and you look at the kids that were included and you look at their cannabinoid regimens, they're all very different. And that is because they've been fine-tuned to that patient. And so we have to recognize that one size does not fit all, including any drug or any cannabis product. And it makes it very difficult. I'm working with families sometimes a year before we find something that works. And it's not for lack of trying, and it's not for lack of following up. Patients they each have their own unique instance. And there was a study out of Israel that showed that boys did a little better than girls on a 20-to-1 ratio CBD to THC, but you know, that was the product being used. Potentially use something else and you may find something different, right?
Dr. Fisher?
I'm not sure how much I can add on this. I don't have any real experience. I will say that just listening to the conversation, we know that autism is more common in boys, and we know that the symptoms are different for different patients. And when you consider that generally that autism is probably a deficiency in the endocannabinoid system, because it's affecting boys differently than girls, then maybe that deficiency is manifesting differently in boys and girls. And I will say also, and this is just kind of pulling this out of the air, we know that boys tend to be more energetic, shall I say, than girls, and maybe they're differentially targeted for testing more than women, and maybe kind of that has something to do with it. And that's pretty much all I can really think of.
Interesting. Janna?
And all that's just pure speculation.
I gotcha.
It's pretty good, pretty good. And of course, I have a daughter with autism, and she is one of the rarer types. For her, we've done a lot of digging into biomedical and contributors for her, and some of it for her does connect back to genetic influences that she received from me that is part of my illness. And so I think with girls, we could maybe come to the conclusion that there are some other factors contributing for them that may not be contributing for the males. And I heard a theory, it's been a long time ago, so I can't even quote the research, but it was a theory that the higher testosterone of males somehow made them more susceptible to autism. So that could, logically it makes sense that could be a link as well.
That's exactly what I was thinking when all three of you were explaining. I was thinking possibly, now I have no idea, I have no medical experience, but possibly the testosterone is trying to make up for the lack of other things because the imbalance in the endocannabinoid system, but that's just a possibility I was thinking.
Yeah. Realistically, a lot, and there are different forms of autism too. Like there's the congenital autism where parents report, kind of a disconnect with their child from the very start. And then there's parents that report regressive autism where the child develops normally, or my daughter was developing ahead of schedule. And then at 19 months, she experienced a very dramatic regression. She literally went from speaking, using sign language, good eye contact, good interaction. She even had a choice cuss word that her dad had taught her that she used one day when she was trying to get up on the couch and couldn't. And she went from that to sleeping 20 hours a month, or 20 hours a night. When she was awake, I was shoving food into her, trying to get her to eat. She lost her bond with pretty much everybody but me. She started having really bad gut symptoms. She lost her sign language. She lost her verbal language. She lost her receptive language. Her sensory system changed dramatically to where she couldn't even handle bright lights or loud sounds. Luckily she's one that does still seek touch, but she tends to seek the really deep touch where, I'll be walking down the hallway and she'll grab me and back against the wall and pull me against her type of sensory input. So, there's different forms too. And I don't think anybody has teased out the genders with the different types either. So there could be some keys there as well.
Yeah, so it seems from what I'm hearing is there's so much more that we need to do on studies with autism in general, but also autism with cannabis. That's where I think the most amazing thing is just the possibilities of cannabis taking over all the pharmaceuticals, because that's the one thing that you guys have pointed out already is when you take a pharmaceutical, all the list of the possible side effects, and then with cannabis, it's like you might feel a little happier. You might want to interact with your fellow man a little bit more. You might want to listen a little bit more intently. And said I'm on a spectrum as I see things in images, pictures, videos. It's just I wasn't able to retain information reading until I was about 24 or 23 years old. It was so difficult. And what I started doing was watching movies or TV while reading. and I would associate the image of what was on the TV with what I was reading. And when I would think back on the show, I would see the book, and I was able to see the words while I was associating it with the image. And so that is where I read 200 books after that. It was amazing. And before that, it was all documentaries. I still do that, documentaries. I love documentaries, but I just love it slows me down. It puts me into a focus mode that I don't have otherwise, or at least that I have to work very hard to attain.
Yeah, absolutely. And we do find with autism that the typical learning processes don't apply. The way that we figured out to educate my child was by following her lead. The first and foremost, figuring out how to have her show us what she knew, because she's very much an autodidact. I mean, this girl knows trigonometry, and I have no clue how. But she passed the trigonometry test. So you tell me, it's clear that they learn in different ways, but it doesn't mean that they're less effective ways, or that they can't learn, which is, commonly with the public school educators. If they don't fit in the box, they want to just, set them aside and focus on the kids that can. And so that doesn't work with autism, is what I have found.
It's also the teachers. It's who you have. If they're sympathetic, if they have the patience to deal, to want to teach you. I started asking questions when I saw Temple Grandin for the first time, and that's when I started seeing that. I was like, "And my mode of thinking is different. Is that what's going on?" Because that's exactly how I think. Those images, being able to just see everything going in your mind. And I found out that that's actually very, very not common. So,
yeah. And we had some wonderful examples that helped me to realize she might have more potential than the experts were saying. When she was 3 or 4, I left my computer open and found her Googling water slides and roller coasters. I didn't even know she could spell. So she showed us these glimpses of what she could do. And really what it came down to, she finally got diagnosed by an occupational therapist as having sensory defensiveness. And it actually made her unavailable for learning in the classroom environment because she was too busy coping. And that's not the time to try to teach someone new information. So once we moved her into the home environment where we could control the light brightness and we could control the environment and really meet her sensory needs, then she just started to learn like crazy. And once we figured out how to test her, we realized we were about 6 grades behind in what we were teaching her. Then she started really progressing quickly, and she passed 2 to 3 grades per year for a couple of years right before she graduated, once we figured out how to test her. So, just because a child is nonverbal or has difficulty communicating does not mean they're lacking intelligence, is kind of the take home for that.
I couldn't agree more. Go ahead.
I would argue that, so the statistics show that the ones that I've seen, that the incidence or prevalence of autism has increased. It's like 400% over the past 25 years.
I saw that in your study.
And what Janna's talking about and what you, Jay, are talking about are teachers who, if they're in a classroom with 30 kids or 20 kids or whatever, it's very hard to cater to anyone who's not mainstream. And so the focus is there and everyone else is just kind of, passed along or pushed to the side. But computers have come around and enable a lot more kind of individual discovery. And so maybe it's through being exposed to or given the alternative, to not just be put in a single path, but, especially with the internet, so much more, a greater diversity is easily available for children to kind of discover on their own. So again, just throwing that out there, maybe the diagnosis has improved since people have stopped being put in such a narrow track.
And some of what we're seeing today, and early on, I was inspired by a couple of people. One of them, Carly Fleischman, who was severe autism, and they figured out that she knew how to spell and began giving her devices to communicate, and just opened up this whole world into her mind and her thoughts. So that caught my attention. And another person. She's on YouTube. Her name is Amanda Baggs, Baggs. She's actually an adult with autism. And I'm trying to remember the name of her video, In My Language, I think it's called. And they showed the first 5 minutes of this video are her stimming and interacting with her environment and, playing with water and sucking on things to taste them and experience them in different sensory ways. And then she sits down at a computer and very eloquently types out how she thinks it's so ironic that people label her non-communicative when, from her perspective, she's more interactive with her environment than the typical person. So there are just some fascinating case studies, and that led me to teaching my daughter how to type. And that really is what opened up her world and us realizing her intelligence level and her capabilities. So awesome. I'm just so thankful we have technologies now. And it's pretty routine these days now for kids, even under age 10 with autism, to be introduced to these typing mechanisms and ways to spell out messages. And so it's really catching on. And I think we're just going to see an explosion of understanding of their experience through that technology. So I'm really excited.
Her story is so amazing. She sounds like such an amazing person, and I'm so happy you guys were able to figure it out and she's able to express herself. That's so amazing.
Just to be clear, it's not perfect. We're far from perfect, but we are manageable. She has fairly good quality of life. She still has a lot of health issues we're addressing, but it can take a while to figure it out. Autism is very complex, and no two kids are exactly the same in my experience. So.
Agreed. Now, here's a really interesting question I got. Are you able to tell if someone is on the spectrum from their anandamide levels, or are you even able to check those from a blood draw to check?
So it's not a routine blood test that's available right now. The studies that looked at anandamide were like university academic studies, but it is measurable. I suspect one day we'll be able to have that on the market and be able to check. What's interesting is that in the study that came out of Stanford in 2018, they blinded the scientists, and the scientists were actually able to pick out which patients likely had autism due to the looking at the anandamide levels. So they actually have this beautiful graph on there in the paper that shows that with certain levels of anandamide, the probability that the child had autism. So yes, they were able to predict, but I don't think it's 100%, of course, because you're going to have some crossover. But it was statistically significant, which means it was not due to chance. And these are definitely compounds that can be looked at. And as I mentioned, there are other studies like in patients with migraines, patients with schizophrenia, temporal lobe epilepsy, where they've looked at levels of endocannabinoids and also looked at receptor density and have documented abnormalities within the endocannabinoid system. Now, one thing to be very careful of is that, remember, it's like the chicken or the egg. So are these abnormalities a result of something else, genetics, or some, drug that was given in the first year of life? Because we know actually now there's a fair amount of research looking at acetaminophen, which is given to every child after they get a vaccine. I'm a pediatrician, so we were encouraged to recommend acetaminophen if the child gets a vaccine to prevent fever and discomfort and pain and all of that. Well, acetaminophen now has been is correlated to the development of autism because it does interact with the endocannabinoid system at and remember, these are very young children that are getting this drug and they're vulnerable. But right now, it would be great if we could check anandamide levels just to have a baseline. But what's really interesting is that the second study that measured these levels, they didn't actually find that there was any difference correlated to other medications or correlated to other diagnoses. It was like just having the diagnosis of autism, you are likely to have low levels of anandamide. And I think that, yeah, it is very interesting. And what's really interesting about using cannabis, we have this saying, as you probably all know, start low and go slow. Well, we're doing that because you don't want, there's no standardized dose. As Janna said, no two children are alike. We just checking boxes to make diagnoses, but these children are very a heterogeneous group. When you start with low dose cannabis and titrate up, you are basically personalizing or customizing the regimen for that child. And just today, I got a question from one of my moms in my email. She saw a study and she was asking me about the study. And in my answer, I had to write, whether your child takes 2 milligrams of THC or 200 milligrams of THC, I don't judge the dose. It's your child's not impaired, non-intoxicated. That's important because we're not trying to impair or intoxicate any child. We want them to be able to participate more in their lives, like not be stoned out. But some patients have a true sensitivity to THC and will respond at a low dose, and other patients, very high doses. But you also have to remember that we don't absorb every milligram, and that some kids don't break down these cannabinoids very well. So you are really looking, when you're first putting a child on a regimen, you're looking for the pattern for that child, right? So are they, and in my head, like I'll get emails, I'll say, oh, super sensitive kid, low dose kid. And then I have other kids that are like mega dose kids, and then everybody in between. And it really is so important to understand that, when we prescribe an antibiotic, for instance, for strep throat, there's a recommended dose, right? Because that's what they studied and that's what they found. But cannabis doesn't work that way.
My thought on that would be, so it's all about the deficiency in the endocannabinoid system. So it sounds like it depends on the levels of their deficiency. At least it sounds like that's one hypothesis.
It is a hypothesis, but be aware that there are studies that have looked at, like, for instance, in children with epilepsy, where they're studying how CBD works, right? Is it effective, at what dose, and so on. What's very interesting is that the blood levels of CBD did not correlate to a response. They just didn't. Some kids with low levels in their bloodstream had seizure freedom, and other kids had high levels and they might have had seizure freedom or not. So it doesn't seem to correlate. So many of the typical epilepsy drugs that we use have a range, what we call the therapeutic range, and you check a blood level. And if they're in that range, then you kind of know you're targeting right. And again, this comes from, it's a single compound drug that is targeting one particular place. Remember, cannabinoids are what we call promiscuous molecules. They target numerous places in the brain and the body, enzymes, transporters, ion channels, receptors. CBD at last count is like 75 different targets in the brain and body. So trying to predict how any one individual is going to respond to CBD, I think is, an exercise that I don't partake in anymore. I just say, let's try it. It's been shown to help your children with who have similar symptoms, and we'll try it and see how it goes. About 20 or 25% of my patients just don't, in general, with epilepsy, autism, or other conditions, just don't do well with CBD. And CBD has, like, everybody thinks, oh, it's the perfect medicine. Well, why don't they respond? It may be that it's hitting targets that we don't want to hit. Maybe in that particular child, hitting serotonin is not what we're looking for, right? And so we have to be very careful, understanding that cannabis should be personalized, customized to a patient, and that in general, yes, THC mimics anandamide and can target that, but that doesn't mean it's going to work.
And to add to what you're saying with CBD, what I've seen is that CBD is, I know there's some value, but it's pretty much worthless by itself. You need just a tiny bit of THC to interact with the CB1 in order for the CBD to actually have an effect. Is that true?
I would say that is true in general. There are some patients that just don't do well with like a whole plant. It's definitely just a small percentage. I've had a few patients who did not respond to whole plant, full spectrum, the full package that Mother Nature gives, and they respond to one, but they are more the rare. That's more the rare patient, and it's kind of amazing that when you give somebody something that targets 75 plus places, and that's just CBD. Think about all the other compounds that are in that mix, right? Targeting so many different things. It's amazing that it works at all, right? But again, I always like to bring the conversation back to is that usually we're talking about people who, when they have illness, by definition, they are not in homeostasis. And these compounds bring you back to homeostasis. And again, to mention my research, what we found with the biomarkers is when the biomarkers were low, cannabis brought it up. When it was too high, cannabis brought it down. Documenting, so objective evidence of the homeostatic nature of cannabis. That's what's amazing about it.
I want Dr. Fisher and Janna, if you guys want to jump in. I know Dr. Goldstein and I have been going back and forth, so if you guys want to jump in, please.
I was looking at some studies on. It was imaging studies looking at people trying to understand why certain people exhibit greater placebo effects than others. And a placebo effect is when someone thinks they're getting a drug, but it's actually a sugar pill. They still respond to that sugar pill as if they're getting the actual drug. And they were going and they were looking at serotonin receptors and opioid receptors, and dopamine receptors, and also endocannabinoid receptors. And what they found was they were looking at people, and they found that people differ with regard to the number of receptors that they have. They differ with respect to the amount of the anandamide and other endocannabinoids in their bodies that will trigger those receptors. And they differ in that when a receptor is triggered, the magnitude of the reaction is different. And people who just react more tend to exhibit higher placebo effects. But this, when Dr. Goldstein was talking and saying that people are very different in the way they react, there's a lot of different kind of differences in there. And the variety, people are just, they differ in different things from person to person. And it's really hard to predict what the particular combination is within a given individual. Maybe at some point they'll have better tests as we understand this more, but right now we're still at the very early stages.
Well, wouldn't it also make sense? I mean, all of our fingerprints are different. Wouldn't it make sense that every one of our endocannabinoid systems are just a little bit different also? And that's a hypothesis that I've had of, just sitting there and having with 5 different people with one strain, and every single person is affected differently. You're just sitting there going, there's something else going on here.
Well, and when you're using something that has multiple compounds, right, that's going to be different. Your absorption is different, your metabolism, your excretion. It's interesting that you mentioned you give one strain to 5 different people. So Dr. Raphael Mechoulam, who is known as the father of medical cannabis, study gave us so much information. My goodness, who unfortunately we lost this year. He did that same study. He took some cannabis home from the lab in the 1960s. And he invited people over, and he and his wife made brownies, and he gave them to his colleagues and friends. And he said, this one hid in the corner. This one giggled the whole time. This one got really deep in conversation. This one fell asleep. This one did this. And so he described how different it can be. And then, when you take people who have different brain chemistry and then give them, right, compounds of cannabis, I think, again, it goes back to the whole one size does not fit all. But that with working with somebody who understands how these compounds do work and what the possibility is, sometimes you can narrow in a little bit better. But I'm looking forward to the day where, the biomarker research that I'm doing is available so that we do have some objective, let's say, baseline data before somebody starts. And then we can compare it 2 months later and see, okay, which biomarkers improve, which didn't. And as we collect data, correlate those to the cannabinoids being used. And we are breaking that open. And whether it's going to be useful for every single person, it's hard to say, but there's no question in my mind that we can do better than what we have now, which is a lot of trial and error. And then I would just want to mention on the placebo effect that Dr. Fisher mentioned. In my pediatric patients, the parental reports may be wishful thinking, I think, sometimes, but I don't see that. My patients don't know what they're getting. They don't know if they're getting cannabis or getting an antipsychotic. They don't know, right? They don't necessarily know the difference. It's pretty crystal clear to the parents when something is working. And I will also say when it's not working, I get feedback because this is out of pocket, expensive medicine. And when it's not working, parents will tell me because they do not want to continue to pay for something that's not working, nor will they continue to give their child cannabis when it's not leading to good outcome. And I think that's really important. That people understand that, because I get a lot of, well, what about side effects and what about this? Well, on the right regimen, and the beauty of cannabis is you can change the timing, you can change the dosing, you can change the product. You have so much flexibility. It's the most flexible medicine I've ever worked with, 33 years in the medical world. So flexible. You can give it every other day if you want. You could take it once a week if you want. You could take it 5 times a day if you want. I mean, it really is customizable. And when you have side effects, which, by the way, the studies show this and it correlates with my clinical experience, it's really just in the beginning as you're seeing how this person interacts with this plant and its compounds. You start to sort out, oh, okay, I see how this human reacts to this dose of this particular compound. And the longer they're on cannabis, the more you're dialing in on their regimen, and the less likely you are to see any really bad side effects. It's usually just in the beginning. And the studies show this, that when you introduce somebody to a medical cannabis regimen, most side effects are in the beginning when you're sorting it out. And they are not long lasting. You do not have to live with sleepiness with cannabis. You tweak it so that it's not doing that for you, right?
And that's what's amazing about today with people like you guys getting into the medical cannabis realm, because I started probably 15 years ago, whatever it was, when I got back from overseas. But it's I had nobody there to walk me through. I just got cannabis. I would smoke an ounce through a week, and I would just be like, I'm happy, but I'm a zombie. I'm not wanting to get out. I'm just numbing myself. And I recognized that myself. So I was like, okay, I'm going to back off. I'm going to stop smoking out of a bong. I'm going to stop smoking blunts all the time. I'm going to start getting a one hitter so I can microdose and actually get down to how much I'm using every time. And I just realized I didn't have to become dull and borderline stupid in order for me to, enjoy my life.
That's very important. And for a lot of people, I think there's this idea now that cannabis is one thing. Cannabis is not one thing. It's so many different things. I mean, I have patients on cannabinoids and people are like, what? What are they taking? So I have one particular patient right now. He's on CBDV, cannabidivarin, and cannabigerol. It's a great combination. Was not a responder to CBD or THC. And if you don't know about these other compounds, how the heck would you even start to experience the benefits from them if you don't know about them or you don't have somebody guiding you? Exactly.
It's so nice to know that people aren't going to have to go through this by themselves. It really is. Just a second. All right. Wife's trying to make sure it's okay to let the dogs out. I'm going to go ahead and progress this. I really want to keep talking, but I have the feeling that we're going to go into a 5-hour podcast here if we don't move it along. Okay. The next question, I'm actually going to tweak a little bit because of what we've been saying. And that is, I want to know, or this is what I've said before on my podcast is, I suggest that people underage, before their brain is done developing, if they don't need cannabis medicinally, to not use it. And that is my hypothesis, is that if you're using cannabis when you're early and you're still developing, you can actually hinder the development of the endocannabinoid system by introducing an influx of cannabinoids. And so it just seems like your body might tell itself to not produce more endocannabinoids if it's receiving an influx of phytocannabinoids. It seemed like a possibility with cannabis. Is that right, or am I wrong?
Well, so the research shows that if you overdo THC, what ends up happening is that you downregulate your cannabinoid receptors. So if you are a chronic heavy user of THC, let's just say, and you're a person who says, well, I don't even really feel it anymore. Well, why don't you feel it? It's because the receptors that were sitting on the cell wall have internalized, because once they're kind of inundated, it's almost like a self-protective mechanism. They migrate into in the inside of the cell where THC can no longer bind to them. This is well documented. There's animal research as well as human research. The beauty of the endocannabinoid system is if you abstain or lower that THC dose, those receptors will pop back out. And there's a very elegant study that looked at the different areas of the brain. And what they found was that, and they took chronic heavy users of cannabis and basically put them in a lab, paid them to live in a lab for about 30 days. And they gave them like a labeled synthetic THC-like substance that lights up where the receptors are in the brain. And what they found was that just after 48 hours of abstinence, those receptors will pop back out. What they also found was that tolerance is what we call regionally selective. So certain areas of the brain may develop more tolerance than others. So it's not just the whole brain, right? I don't know that I've not seen a study that anybody documented that you don't make enough of your endocannabinoids because of cannabis use. I think it's more about the receptor density. And one thing I'd like to point out, though, is that young children, in an early study that was done in Israel, it appeared that younger children, like prepubertal children, remember, they have an immature brain to begin with, and it appears they have less cannabinoid receptors than a mature human brain. And so it's counterintuitive, but children tend to be less sensitive to the effects of THC. Dr. Meshulam and another doctor, I might sure want to say his name right, Abramahov, I believe, did a study in 1995 where they took pure delta-8 THC, which is an isomer of delta-9 THC. It works pretty much the same way, just a lower potency. And they used it in children who were getting highly what they call emetic chemotherapy that is very likely to cause you to have severe nausea and vomiting. And they gave these kids fairly high doses of delta-8 THC. And it was a very interesting study in that none of these kids were high. None of them had bad side effects. It worked great in all cases, eliminated vomiting. And then after 1995, published the study, and then nothing was done with it. But it did show us that children can tolerate THC at this young age. Once you start to have brain maturation during the teenage years, I agree with you. If you are not ill, if you do not have a medical reason to use cannabis, look, smoking some pot with your friends every now and then is probably unlikely to harm you. However, chronic heavy use is probably not a great idea, because you do not want to interfere with kind of what I call the laying down of all those last bits of maturation of the brain. And even though the brain is really not mature, we're finding out until a little bit later in life, it seems to be that between the ages of like 13 and 18, there is a vulnerable period. Now, I do want to just shout out here that when there's an underlying medical problem, it's not the same story. Kids smoking pot with their friends behind the high school is not the same as treating a child who has a medical condition. Not even close. Do not compare them. Do not put them on the same plane.
Mm-hmm. I completely agree. When they're smoking a doobie back in the back, there's no way to tell what that is. I guarantee you they don't have a COA. They don't know what's in that. There's the only therapeutic value anybody's getting is they're not as angry. They're not as stressed.
And they're probably medicating something, like as Janna said, and I think it was Dr. Todd McArea, who was a pioneer in California in medical cannabis, who was the one who said all use is medical use. So, look, teenagers are, especially these days, my goodness, so much anxiety, right? And so much difficulty negotiating the world. I look back to the days where we didn't have social media, we didn't have cell phones. It was much easier, right? And I don't think that experimenting with cannabis here and there is going to be an issue. But what teenagers don't realize is that by overdoing and by kind of downregulating those receptors, you are taking away the target of your natural endocannabinoids. And your natural endocannabinoids regulate your emotional being. They regulate a ton of physiologic function that now you have somewhat kind of lessened and dampened down, which may not be a good idea.
Yeah, I'd like the way that I understand it is when you're young, your body's developing, and it's as Dr. Goldstein said, kind of laying down the foundation. And you have all these chemicals that your body produces naturally, and their purpose is their communications, and they're telling different parts of your body what to do. And the way that you might think about it is, imagine you're building a building and you have all the construction workers there and you have someone who's telling them all what to do. If someone else comes in and starts flooding it with all these new pieces of information, and people are now building in funky ways because that wasn't kind of the original plan, the building you're going to end up with is going to be really funky. But once the building has already been established and it's already set, then coming in with new communication system isn't going to have that same permanent effect that you would have if you were to do that while the body's still kind of developing. And that's kind of the way that I understand it. And I also fully concur that children who are using it for medicinal purposes are very different from people who are not using it for medicinal purposes. And I've read a lot of studies, and the first thing when you're talking about pediatrics, the first thing that everyone says, they say it anyway, whether it's non-pediatrics, but especially with pediatrics, the first thing they say is there's this huge potential to impair cognitive development. That's kind of the phrase. And the comment or the thoughts I have, and I'm sure Janna and Dr. Goldstein will, have very particular views given their much closer touch with actual patients. But when you're talking about a patient who has legitimate medical problems, the thought of maybe potentially having some cognitive impairment versus all of the real symptoms that are going on when a child really has a particular need, that's, to me, you need to balance all the positive and negatives together. And I want to give a particular example that it resonated with me so strongly. And I was doing a study of cannabis for pediatric oncology. And at the very beginning of the study, the researcher said, you have to keep in mind that cannabis can cause, cognitive impairment or deficiencies in development. And then I was reading through the study, and they took a bunch of kids in this pediatric oncology center, and they gave them some cannabis. And I'm reading this, and they're tracking the results over time. And then they got the outcomes, and they said almost all of the children who ended the study reported massive increases in quality of life. And I'm thinking, okay, wait a minute. The number of students who ended the study is much smaller than the number of students who began the study. I guess a lot of them dropped out, maybe adverse effects or something. No, it turned out that a significant portion of the patients actually died. And so you're talking about giving a patient an improved quality of life when a lot of the patients will die. And the researchers there were overly concerned. They started the study. They ended the study with, you must, understand that cannabis can cause deficiencies in cognitive development. And I'm thinking, okay, this is the least of the problems that these children have. And that was kind of my attitude. And I will say, kind of as an epilogue on that, I said, okay, wait a minute, let's look at children who have cancer when they're young. What happens to them when they get older? And it turns out that the vast majority of children who had cancer when they were young ended up having severe psychological and social impairments as adults. So, and again, not to minimize the potential for negative effects in cognitive impairment, but again, you're talking about a population of people who have much bigger problems. And I thought that the concern with this small potential for cognitive impairment was so misplaced by the researchers. And I see this over and over again. And I just kind of wanted to put that out there.
It's also one-sided, and I just want to chime in. There are no studies on children under the age of 12 or 13 using cannabis, period, in terms of recreational use. There isn't any, right? Every study that we have on a child using cannabis in that age group is from epilepsy, autism, or other conditions, and they all show, in general, benefits, right? When we look about the doctors who are worried about cognitive or developmental impairment are basing all of their knowledge on studies of teenagers or young adults with chronic heavy THC use. That is not what we do with medical patients. So it does not cross over. This idea that that's what I'm doing in my practice, or that's what Janna's doing with her daughter or her patients that she's helping, is that we're just saying, here's some THC and have at it, go to town. That is absolutely not what's happening. We include lots of different cannabinoids. We never, ask my patients, ask the parents, the children are not impaired or intoxicated. And if they are, they let me know because we have to adjust something, right? What's really interesting too is that there are some more recent studies looking at the chronic heavy use and question of what is it doing, right? And they're saying, and there's some twin studies now where one twin was a chronic heavy user and one wasn't, and they're saying that it actually might be more due to genetics and other environmental factors than the cannabis use. And look, a lot of the data is conflicting because people come to do research and I'm sorry to say there's biases there, right? There are absolutely biases. I have pediatric patients who are unable to go to school, and look at Janna's daughter. Janna already gave this example, where cannabis actually allows them not only to go to school, but to have school success. So where's the developmental and cognitive impairment, right? I also want to point out Dr. Stacy Gruber's research. She looks at medical cannabis patients and she's looked at recreational use. And what she found was there's different use patterns. Patients using it medically don't even approach what they call cannabis use disorder. They use different kinds of cannabinoids. There's just not, again, that same comparison. So I think it's really unfortunate that here we are in 2023. California's had medical cannabis for 27 years or something. And we still have physicians, researchers, and others that when we talk about medical cannabis use that bring in the concerns of recreational use. I think we all have been able to separate out opioid use for people who really have chronic pain, who use their medication responsibly and so on, versus somebody who has a drug problem, let's say with heroin or fentanyl or opioids, right? We're able to separate. But somehow with cannabis, it hasn't translated over. Everybody's kind of lumped in to, Stonerville. And I just don't think that that's really fair. It detracts from what this plant can do for sick people.
It's also what is propagated, what the algorithms allowed to get popular with cannabis. I mean, if I was smoking on my videos, if I was telling everybody, hey, let's light up a joint, I'd probably have 50,000 subscribers by now, but that's not what we need. We have so many people talking about how great cannabis is to smoke by yourself, and that dilutes the medical cannabis talk. And there's so much to it. I mean, I was just looking it up. I don't have it pulled up, so I can't remember his name, but he's a doctor that talked to Congress in 1937, and this is what's that?
Lester Grinspoon.
No, I think it's Woodrow. It's like Woodrow something. Woodrow Wilson. I know it's like president. It's something like that. But yeah, he was a doctor who was a lawyer and a doctor for the American National Association.
American Medical Association.
Yes, sorry. Yes, the American Medical Association. And he was talking to Congress and basically saying you should not make this illegal. It has so much benefits. It's been in the pharmacopoeia since 1850. It has so many known benefits already, and so much more that we need to discover. He was like, this will be a detriment to humanity, or at least to our country, if you do go ahead with this. They didn't care. They're getting paid.
There's been multiple commissions. There was a commission in India in the 1800s. There was another commission, a couple of commissions in the 1900s, and they all kind of concluded that there's no reason to take cannabis off the formulary. It doesn't cause long-term issues. It doesn't cause. Now, look, somebody who has a chronic problem with cannabis and overdoes for a period of time and has some underlying susceptibility, I'm not going to say that that person didn't have a detrimental effect. But again, we are not talking, that person is not using it properly. If they're using it for medical use, they're not using it properly. When I look back at all of the patients that I have tried to help over the years, true medical use either results in benefits or it doesn't have any effect. You very rarely see someone with true detrimental effects from, again, medical intent, the intent to use medically. And some of my patients, my adult patients that I still follow, many of them just use THC, but they're just moderate users. They don't overdo. They're thoughtful about it. And in my pediatric population, there's nobody just on THC. They're all using kind of combination cannabinoids because they're ill. And I joke around, but it's true. If you're in my office with your child is not doing well. You're having real issues. And likely the medical community is unable to meet your child's medical needs because the vast majority, over 90% of people who end up in my office have not only seen one specialist, they've seen like 5 specialists. They've gone cross country. They've gone out of the country. And so you have to remember that the population that we see, especially in the pediatric world, is what most people would refer to as refractory patients, meaning very difficult to treat, where the options are not great, if there are any. But also just coming from a harm reduction, I'll tell you right now, as a pediatrician for 33 years who has lived on both sides, I would put my child on cannabis well before I would put my child on some of these pharmaceuticals that are recommended, especially for autism.
I just talked to an autism patient in the UK, and she was saying that to be able to get medical cannabis in the UK, you have to prove that you went through every other mode of medication, of treatment, to be able to say that medical cannabis. And I was sitting there going, what's the point then? You've already destroyed yourself by that point.
That's very unfair.
Yeah.
And it's cruel. It's inhumane. And it's decision like that is made by somebody who doesn't understand cannabis medicine.
Amen.
And who has not treated anybody. And that's one of my biggest pet peeves with this kind of the idea of cannabis, is that people who don't know anything about it other than the reefer madness nonsense are the ones making the decisions. Why should a family whose child is finally well not be allowed to travel across state lines with their THC medicine that contains a little THC? I have families that say, my child's actually well enough now to go visit grandma in Texas, but we can't go because we're terrified that someone's going to confiscate our medicine, or we're going to get arrested at the airport or in Texas. Sorry to call out Texas, but in general, there are states who who are friendly and states who are not friendly. And think about that your child's now finally well enough to travel, but yet you can't travel.
So sad.
Because your medicine can't cross state lines. Why? Why do we have this? I mean, I can cross state lines with opioids. I can cross state lines with Adderall. I can cross state lines with antipsychotics. And those drugs are more likely to kill you than give you benefits. So
let's not even go to the hard drugs. Acetaminophen. You can overdose on acetaminophen so stinking easily, and everyone goes, "Oh, well, I'll take Tylenol. That's fine, but not cannabis. I don't want to be a drug addict." And it just kills me.
Well, it's look, it's many years of propaganda. We've all been brainwashed,
Thanks,
and luckily. Now, luckily, we're learning more. I think that parents whose children are unwell, they will, if they have to, they'll go to the moon to try to find the solution for their children. And luckily, the laws are changing, although I still see the ignorance and the willful ignorance, as Janna has called it.
I really suggest, if you do not know, like anybody watching, if you do not know the history of cannabis, I highly suggest you check out my episodes or just look it up. I have the links to everything I do in the descriptions. But let's just think about, in 1944, the LaGuardia report came out in New York, and it stated that it showed that there is no correlation to addiction in cannabis. And then the Schaefer report came out in the 1970, 1971, but Nixon said, "I don't care," and then went on to war on drugs. And 1925, the League of Nations, they got together and they said that within 30 years, they want recreational cannabis usage to stop worldwide. And I'm just sitting there going, why on earth would that be an issue for the world? Why not world hunger? Why cannabis usage? Yeah. Then you realize when opiates started to become popular.
Yeah. Cannabis competes with way too many big money,
tobacco, paper,
pharmaceuticals, which are the primary contributors to all politicians. That could have something to do with it. I mean, I have video where I was testifying at the healthcare committee for Oregon Senate, and the co-chair was turned 90 degrees from the screen, scrolling on his phone during our testimony. Legislation. That is the very definition of willful ignorance. So frustrating. But just to kind of add to what Bonni was saying, you had asked about the anandamide levels, and while it's hard to predict those, we are beginning to map the endocannabinoid pathway genetically. And I just posted an article about this on my Instagram account. And really, there is a mutation that is known to predispose intolerance to THC and potentially increase the risk of THC triggering schizophrenia. It's called the AKT1 gene. So I think as we continue to evolve in these other areas that cross over with cannabis, we're going to improve our assessment of the risk factors and our ability to maneuver around them, right? Right now, most of us just ask the family members, do you have any family history of schizophrenia? Because that is a consideration. But we're getting to where I think at some point we'll have genetically guided cannabis therapy where we're looking at the individual from that very deep level and being able to accommodate their needs through that assessment.
And biomarker information, because genetics tells you your potential, but the biomarkers, this is why I was so engaged by this company who's doing this research. It actually tells me what's going on in your body right when I collect those biomarkers. And so what would be great is to have both the mapping of the genetics, connect it with what we call the genotype and the phenotype, so that you can understand actually what's happening in this person. One thing we haven't talked about, and I just want to bring up, is that many of the cannabinoids found in the cannabis plant enhance your endocannabinoid system by blocking the breakdown of anandamide. So they actually tell your body to do a better job with the endocannabinoid system. And I think that's important to understand, and that we talk about something called the endocannabinoid tone. So these compounds actually enhance that tone. And for some people, just a little bit of cannabis seems to kind of balance them out and make them feel better. And I think for some of those people, they get just such they just get from that anandamide deficiency, they end up kind of achieving that anandamide homeostasis just with a little bit of cannabis enhancing their anandamide production and their endocannabinoid function. So I just think it's really important to understand too that the endocannabinoid system touches so many of the different neurologic pathways in the brain. And Dr. Fisher referred to this before. Serotonin, right? Dopamine is under the control of the endocannabinoid system. There's inputs, what we call GABA, which are inhibitory inputs, and the glutamatergic, which is your excitatory inputs, and the endocannabinoid system regulates all of that. It's so important. And I just want to also point out that the endocannabinoid system is not being taught in the medical schools. There's something, I think my last count, maybe Janna or Dr. Fisher, if you know, something like 14 or 15% of medical schools actually educate their soon-to-be physicians about the endocannabinoid system. So how are you supposed to help people who have difficult or treatment-resistant conditions, or let's just say not responding to, conventional treatment? They go from doctor to doctor to doctor to doctor, and nobody mentions, well, you know what, you likely have an endocannabinoid issue, and we should probably address that. It's not even a thought. I have patients that 10 years of chronic illness and suffering who after 6 months of cannabis are back at work, they're off all their pharmaceuticals and they're doing great. And it was like, oops, we missed the target for 10 years. It really drives me crazy. And I want to say that a lot of women who go through this are kind of, they get the eye roll from the, sorry to say, male doctor who says, oh, she's just crazy, right? It's all in her head. And I joke around, yes, it is in your head. It's your endocannabinoid system in your brain that might be causing some problems. And we know chronic illness, chronic sleep deprivation, poor diet, not being able to exercise, all of that contributes to further endocannabinoid dysfunction.
One thing I've seen, it's a theory put out by a bunch of different doctors, and I also learned this from my history, is that cannabis was a staple in our diet before the prohibition that was put on it. Cannabis seed, cannabis flower, and they theorize that one reason, not the only, but one reason we have a rise in such diseases, cancer, all that, is that we're not supplementing our endocannabinoid system with those, not necessarily smoking it, but eating it as a vegetable and getting those acids. And that was one thing I found very interesting, because of all I've seen with THCA and cancerous cells.
Well, not to mention that we used to feed it to our livestock. So we had cannabinoids in our byproducts, the milk, the eggs, the meat, that just disappeared in 1937, which coincided with this explosion of chronic illness in our country. So it's pretty clear. I mean, I think we need to start teaching our medical professionals when they're not competent. We see things like flippant labeling of addiction disorders like cannabis use disorder, when a competent medical professional could step in and say, hey, let's tweak up your regimen. Let's focus on the non-intoxicating compounds during the day so you can be more effective and more functional. And, if you need THC, let's do that. I mean, just simple tweaks can really change decreased function. And we need to teach medical professionals that daily use, which is one of the DSM criteria for cannabis use disorder, may be appropriate for somebody that has endocannabinoid deficiency. And it's not necessarily a dysfunction. And we do have research that supports when patients have really competent guidance, they have fewer adverse effects and better outcomes. So I think education is so important. And, it's so hard to be taken seriously in this business as a medical professional, and we really need to shift that. And I think as more patients report to their doctor and say, hey, my blood pressure is down since I've been taking CBD, can we reduce the medication? We're going to start really creating even more awareness in our physicians that are naive, and hopefully perk their interest and their curiosity and have them start doing this autodidact journey that many of us have taken on the call today.
It can even benefit people who like to use it recreationally. Let's say you figure out what strain works better for you, and it starts affecting you better, faster. It'll start saving you money. You're not buying stuff that's not working for you. Let's say for pain management, you get a new strain, it just doesn't do that pain for you. You can really narrow it down. That's one reason I've always said to track, your usage. It's difficult. Typical American, I started this podcast just thinking of people next door, and then all these people rushed in with comments around the world going, it's not easy for me. I don't have a dispensary down the road to get a COA on. And I started thinking about that. It's like, you're absolutely right. You don't even know if the person telling you what the strain is if that's the strain. Back where we were 15 years ago,
Yeah, and that's really vital. And part of what I've done in my formulating, and we did win best CBD or top 10 CBD of 2020 designation with Unity formulas, is that they are targeted. And so the ingredients, he starts with a whole plant base, which I think is vital, and then tweaks the terpene profile or combines cannabinoids in a way that's evidence-based for targeting specific symptoms. So, for example, the anxiety formula has CBD, which is research supported as an anxiolytic, with myrcene, which helps everything cross the blood-brain barrier, get to where it's needed, and linalool, which is anxiolytic in its own right, according to the research. So these are, and then the other thing is, once a patient finds what works, they can access it consistently, which is really difficult to do with dispensary flower. So there are ways to enhance medical use through some of those strategies.
All right.
I want to plug his book. Can I do that really quickly?
Yeah.
So I'm actually I'm teaching. I teach at John Patrick University and I teach medical cannabinoid science to future functional and integrative medicine students. And Bonni Goldstein's book is my textbook for a course I'm creating now that launches in January for our nutrition degree students, teaching them about cannabis and the vital nutrients in this plant and its potential. My other course is CBD and cannabis formulations, which really dives into the botany of the plant and all the compounds, which is, information I've used to do some of my other roles in formulating. So, it really is something that we're trying to bring to formal education and have resources for medical professionals that want to be educated. And, whether they want the college credits or they want to just audit the course or get the degree, there's so many different options. So it's really wonderful to see it entering formal education.
I agree. When I saw that the American Nursing Association just made cannabis nursing a real thing, I was like, yes, finally.
Yep.
I
wrote an article about that for American Journal of Endocannabinoid Medicine, and my next article by them is on autism. So watch for that. Should be out in the next couple weeks.
Oh, I'll be watching for that. I'll definitely want to.
So
go ahead.
Nice enough to give me some quotes and I'll be highlighting her research as well. So
awesome.
Yeah.
All right. We have two more questions. Some say cannabis seems to cause intrusive traumatic memories. Is this common?
I have not seen that. And again, medical use, proper supervision, I do not see that.
Lab tested, no fentanyl in it. That would be important to check if they're having that kind of response.
Right.
What I was going to say was I didn't want to give medical advice, but I was like, you might want to see what else you're taking there.
I was just going to mention, though, there appears to be, as Janna mentioned, some genetic, underlying genetic variants or differences. That there are some people who just do not tolerate THC very well. Even a low dose, they do not like it. It makes them feel weird. They don't like the way it makes them feel. We all know people who are like that, and that's fine. But remember, if you rule out THC, that does not mean you have ruled out cannabis, because like I said, it's not one thing. We've got a ton of other cannabinoids. So when I first started working in this field in 2008, all we had was THC. It was unlabeled, unreliable, but meanwhile, people still managed. Okay. At least it was in California anyway. They had a piece of paper that made them not get arrested. Okay, so at least, no matter where they were getting it, they could prevent arrest. But additionally, what's important to think about is that then we had CBD around 2012, 2013, and then we had THCA available on the market, and then we had CBG available, and then so we've slowly now have all of these cannabinoids out there. So anybody who may have an issue with one particular cannabinoid, that does not, I will tell you for sure, does not cross over to some of the other cannabinoids. They have some overlap, but they also have some individual targets. And just because you may not tolerate one does not mean you won't tolerate the other. In my book, I write about rule it in or rule it out. Start with the best, like Janna said earlier, you're working with somebody who says, well, you know what, for your particular situation, I would start here. I might not be right, but we rule it in or rule it out. Ruling it out means it's not helpful at any dose. Ruling it in means you found a dose at which it's helping you. Then what I do with my patients is if there's still room for improvement, I go to the next cannabinoid in the list, rule it in or rule it out, and kind of work our way through. And the other thing to think about too is, and we were talking about this before about, smoking joints or bongs or whatever. Anytime, if you notice on the media, when they talk about medical cannabis, like on local news or anything, they always show somebody smoking a joint or a bong. And it drives me crazy because they're talking about medical cannabis. Now, some people might use it that way, but why wouldn't you show somebody using, a syringe measuring out a dose? Make it look medical. And that's unfortunate that we don't see that, right? We see this kind of other side to it that makes people feel bad about their medicine, especially older people who have lived through the whole reefer madness and so on. They say older people elderly don't tell their doctors about cannabis because they're worried that their doctor's going to think they're stoners or potheads. That's so unfortunate. We're keeping information from your physician. Not a good idea. But I don't blame you if they're judging you.
No,
I kind of get it.
I know people who are alcoholics and they take pharmaceuticals every single day of their life and they say, I don't want cannabis. I don't want to become a drug addict. And I'm like, okay. This is what I was going to ask is CBDP. Do you know about that? It has a 7 alkyl chain, I believe, and that's why they're saying it might be more potent. Not that anybody listening cares, but I'll just really quickly. It's the alkyl chain, basically the tail of the cannabinoid, and that's what attaches to your CB1 or CB2 receptor. It's what grabs on, and then what gives it. And I think it's between 3 and 9 is the alkyl chain, and 9 is the strongest, and 3 is the weakest. And THC is at a 5. THCP is at a 7, and that's why it's supposedly. I hear it is, but I haven't actually seen it myself. So it's supposed to be a lot stronger.
Right. This is true. The longer the alkyl chain, the more potent the compound. And right now there's a lot of synthetic cannabinoids on the market. People are converting CBD to delta 8 THC and delta 9 THC. And those two compounds, whether they're made synthetically or come from the plant, work the way they work. They're the same. But the problem is that when you produce delta 8 THC or delta 9 THC from CBD, you also make byproducts. And those byproducts are these synthetic cannabinoids that have potentially dangerous side effects. They're like synthetic cannabinoids, like K2 or spice, and they bind to the receptor. What they talk about is 50 to 100 times more potency, and can cause really significant psychiatric condition, renal impairment, cardiac issues. They are not safe, and they've certainly not been studied at length. The report came out in December of 2 young people, one 20 years old and one 35-year-old, that entered into a Colorado emergency department after vaping delta 8 cartridges. And I just want to put out there, it is not delta 8 that is the danger. It is the contaminated, the byproducts and contaminated likely synthetic cannabinoids that almost are unknown. There's also a very nice report on the market where they gathered up a whole bunch of these, quote, delta 8 cartridges, and they looked at what's in them. And there are some things in there that nobody's ever discovered before. When you're making this stuff in your house or in a factory that has no regulation, it is truly buyer beware. And if you have an underlying psychiatric condition, I would be very, very careful. I tell patients, please, please, please know your medicine, know your COA. And even if it's all recreational use, the same thing. Clean is always better. That's what you need.
I do want to add that when you're talking about THC products, those are within the marijuana industry, and all those products are theoretically required to be tested. However, when you're dealing with CBD dominant products that don't have a lot of THC in them, then you're in the hemp market, and technically none of those products are required to be tested. Certain states or certain places do have requirements that you test them, but generally speaking, they're not required to be tested. So when you're talking about the Delta 8 stuff, that falls within the realm of hemp or CBD, and most of that stuff is just not tested.
And actually the DEA has come out and said that Delta 8 is not a hemp and it is illegal. The problem is just enforcing that. They just can't because there's so many people now. It's flooding the market. It's absolutely flooding the market, and it is buyer beware.
Well, THCP, I think, might come out if it's stronger than THC. And if you can then make it with CBD, then you're going to end up having THCP that's really, really strong in untested products in the hemp or CBD markets. That's going to be a real problem.
I'd really like to see Delta 8 become a thing because the way I described it to people was I would always get to the crest of a mountain, but I could only look over. I could never cross it. With Delta 8, I never seemed to get to where I felt too stoned or anything like that. I could use it throughout the day, all of that, which was nice. It's just the byproducts, the other feelings that it would give me from the propylene glycol and, like you said, the byproducts. So I would really like to see it organically become a thing, but I don't think it's not really feasible to do it in the high amounts.
I would agree there. I think there's utility for Delta 8 THC as a medicine. And even if somebody said, I don't really like the way Delta 9 makes me feel, it's a less potent experience. But the problem is, of course, again, the unregulated products. And again, I lived through, as a cannabis physician now going on 16 years, I've lived through the unregulated market. And as I think it was Janna mentioned, if you are using a medicine and then you cannot get it again, that is like one of the worst things that you can do to someone who was suffering, who found relief, and now it's not available. So I often will just make sure that my patients are using products that I know are stable, they're on the market, whether the hemp market or the medical cannabis dispensary model, so that I don't even sometimes venture out because I don't want to find out that I put somebody or recommended something to somebody who then they can't follow up and find it. We already have so many issues. I have patients using THCA to control epilepsy or autism symptoms. And about out of the 5 products that we had on the market, in the last, I'd say 10 years, we're down to 2. Now, where did they go? The companies went out of business. They don't have it anymore. And people have said, well, just use something else. Well, everybody here knows that sometimes somebody doesn't respond to this over here when this particular chemovar was what helped them. So this over here, just because it's got THCA, does not mean that it's going to have the same effect as this other THCA. And this is a real issue with cannabis medicine. I think everybody involved can understand that it's important that, especially for companies that go into this, you realize you have patients at the other end. And as difficult as it is, and I applaud all these companies for trying to jump through all the hoops to get properly tested, quality grown cannabis as medicine. There's nothing easy about it, but that's one of the biggest problems that I'll see. But at the same time, I have patients who've been with me for 10, 12 years who are doing great because we found something that works. And luckily that product has been on the market.
Janna, you have patients. You want to chime in here?
Yeah. Trying to think what I wanted to add. I think we've covered so much.
I know.
A decade ago or more, when I became a patient in Oregon, the only products that were available to me were homemade quality. They were not lab tested. It was only THC and THCA. That was it. So today we have, a much better range of products to offer to patients. And just to be fair to the THC, there are also people who don't tolerate CBD. And autism is one of those areas where we do see CBD intolerated, and we see, people who try CBD and they see the autism behaviors exacerbate. So it's not just about the THC and how people might not tolerate that or might react badly to that. There are considerations with the CBD and some of the other cannabinoids as well. And of course, we have so many different aspects to consider, even beyond the individual and their response and their pre-existing baseline. But the fact that some of the cannabinoids have a biphasic effect. So they work very differently at low dose than they do at high dose. And so I really think the answer comes back to education, making sure we have competent medical professionals to serve these patients and guide them appropriately. And until we have that, patients are going to try to go it on their own. And I wrote an article about the demise of medical cannabis in Oregon and talked about how all we're giving our patients is a signature. Most doctors here don't educate at all. And it's likened to a patient walking into a pharmacy and eeny, meeny, miny, mo with the medications with no medical guidance whatsoever. Many don't even understand that CBD can interact with pharmaceuticals. And we had our first patient death attributed to the combination of CBD and the wrong pharmaceutical in 2020, the meloxicam drug case study. I think it also had to do with the fact that the CBD that she started was a liposomal and boasted increased bioavailability. And 3 days later, she died of a known side effect of the meloxicam, which is Stevens-Johnson syndrome. So, we can take lessons from all of these outcomes. And, that's a big point I try to make when I'm teaching, is that patient outcomes are evidence. And in fact, they are the closest thing we have to human trials, which are lacking in cannabis therapy. And a lot of times it's the patient outcomes that prompt our research topics. Like, hey, how did that happen? Let's investigate. So I think, we still have a long way to go. But I'm just so encouraged that we have such knowledgeable professionals like Dr. Goldstein and Dr. Fisher today that are committed to these patients and really helping to push this industry forward. So this has been a lot of fun. Thanks for having me.
Oh, of course. I'm so excited. I've noticed there's so little about you guys. There's a lot of literature out there. Like I've said, most people are becoming so much more visual now. They want to see it. Very few people are reading, and that's why I want to showcase it. I wanted to bring it. That's one of the main reasons I started this channel. Was I saw so many people blowing smoke into the camera saying, let's end the stigma. And I'm like, you're propagating the stigma. Let's actually end the stigma with medical cannabis. Yeah. How about we do that?
Yeah. Yeah, even being in the medical industry, one errant giggle during a conversation can totally blow your reputation and any inkling they have towards looking at you as a professional, And so, especially as medical professionals, we have to be so careful about that. At the same time, breaking the stigma, but teaching first from the medical perspective is how we're really going to reach other medical professionals, I believe. So.
Yes. And Dr. Goldstein, I've talked to people in the UK, France, and they all hear about you. Like, they were so excited they're going to be able to hear from you. They're like, oh, I've seen her speak. I can't wait to hear what she has to say. So I was so excited. I was like, man, I can't believe I've got someone so well known to come on the podcast.
Well, I didn't plan it that way. It just happened.
It's the last question. What are your thoughts on administering THC to overweight individuals and or those with metabolic conditions?
So THC in overweight individuals actually can propagate further obesity and metabolic syndrome, okay? So as much as you can have an endocannabinoid deficiency, you can also have an overactive endocannabinoid system. And what happens is your fat tissue, your adipose cells, that's what we call like fat that we accumulate, your fat cells actually make more cannabinoids, endocannabinoids, which then kind of make you hungry, which then make you eat and lay down more fat, and you get into this vicious cycle. And there's a syndrome called metabolic syndrome that is associated with obesity. and it seems to be endocannabinoid driven. So by blocking the endocannabinoid system with a compound such as THCV, tetrahydrocannabivarin, has been known to help reduce metabolic syndrome. So by blocking the CB1 receptor, you can actually mitigate some of those side effects. Or some of those parameters. There is actually a study where they took patients and measured their anandamide. There were it's just two men who I think they were obese, and they measured their anandamide levels, which were kind of sky high, and they put them on a rigid kind of diet and exercise program over a year and followed their anandamide levels, and their anandamide levels dropped over time. And remember, this was no intervention with cannabis, just the just diet and exercise, but it normalized their anandamide levels. So you don't want too much anandamide or too little. Again, homeostasis is what you want. And so there is this described kind of overactive endocannabinoid system.
And I saw the viewer question, and it's actually someone with autism that also has obesity. So we've got the anandamide deficiency theory, and then would you change anything based on that information?
For me, I would probably just use I would probably use other cannabinoids. So I would try CBDV, I would try CBG. A small amount of THC might be okay. And then I would try to incorporate a very, clean, healthy diet and see what works for that person. I know we all talk about clean diets. Some people are vegan, some people are keto. It's just like cannabis. It's not one size fits all. You have to figure out what works for you. But when as a cannabis physician, sometimes it's not just cannabis, it's also other medical advice, other wellness advice, trying to help that person maximize how cannabis works. If your gut's a mess, I can give you all the cannabis in the world, and your microbiome being a disaster, they're just negating each other. You're just not going to get anywhere.
Intermittent fasting.
What?
Intermittent fasting.
Well, in children with autism who are very particular about what they eat, this is a real issue. I have patients who only will eat truly. It's not even food. It's food-like substance. It's packaged, processed garbage, and the child won't eat anything else. And how do you fix that? Right? That's a very difficult issue. Sometimes cannabis expands a child's palate, but sometimes it doesn't. And so we have to reach into these other kind of silos and try to help, manage patients some other ways as well. Like cannabis is great. We've all talked about how great it is, but at the same time, sometimes it's not the end all be all, and people need help in other areas as well. So that's what I would do, Janna. I wouldn't completely eliminate THC. I would just try not to make it a big part of the treatment. I would probably use the other cannabinoids and see where I could get with those.
I think she had said specifically, she wondered if 20 to 1, like 20 CBD to 1 THC, if that would be feasible.
I mean, that certainly could be feasible. It's just one of the options. Remember, as Janna mentioned, biphasic effects of CBD, sometimes at very high doses of CBD, like in the hundreds of milligrams, which some patients require, it actually decreases appetite. And in studies on Epidiolex, which is the pharmaceutical FDA-approved drug, that actually has been shown to, in some patients, to cause weight loss because it decreases appetite. Not very common, but it happens. It's a known side effect. I've found CBD and THC as well. There are people who use THC who say they don't get hungry, or it has no effect, or it makes you ravenous. I've seen every outcome with CBD, every outcome. It makes you hungry. It doesn't have an effect. It decreases your appetite. I think, like you said, which is something that I say all the time, we all have individual fingerprints, right? Why wouldn't we respond to cannabis differently than our neighbor or our sister or our best friend? It just makes sense to me that you're allowed to respond how you respond. And you learn that about, and when I'm taking care of patients clinically, I document all the responses so that we can kind of try to understand that underlying physiology in that patient. And sometimes it's, we only understand so much, and there's so many different things affecting outcomes, your diet, your genetics, your living situation even? Are you in a toxic living situation where you're constantly stressed all the time? Cannabis is only going to do so much in that situation, right? So...
And it might keep you from actually addressing certain issues if you're using it to numb yourself out. That's one issue I found myself is I just used it to numb, and I wasn't getting better because I wasn't addressing the actual issues.
Yeah. And I think for the most part, a lot of people recognize it though, because they realize I keep buying this stuff and it's not making me feel better. So they eventually have some epiphany that says, gee, maybe I should change my patterns.
For me, it was, I can take tolerance breaks, and the first use after a tolerance break, it will be nice, but then there's no change after the first one. And so I very rarely, I learned to microdose just about every single day. And I mean, I've been using for 10 to 15 years, and there's still people that find out and they go, I've known you my whole life and I didn't know you smoke cannabis. I'm like, that's because I don't get stoned. You don't have to get stoned all the time. I mean, it still alleviates all my stress. It still alleviates this, but I'm still able to function and have a conversation. I might get a little bit too carried away and get a little bit too happy, but that's about it.
There are worse things.
Isn't that the truth?
Why is euphoria being demonized? I don't understand.
It's true. If your medicine makes you happy, apparently that's a bad thing.
It's crazy. I mean, don't we want to be happy? I mean, isn't that the point of the medication they give people for psychiatry is to make them happy?
To make them happy. And I would like to bring it back around to autism. That's one of the biggest things that parents will tell me. Is my child is showing evidence of joy. They're happy. Mm-hmm. Because when you think about, so the indication for the 2 FDA approved drugs is the irritability associated with autism. That's the actual way that they've been approved, is to treat the irritability. And I personally think it just tranquilizes the child so you don't see the irritability.
Yeah.
But you don't see improvement in the core symptoms. You don't see a child smiling. You don't see a child running around with joy. And I have parents who tell me all the time, my child is happy and playful and engaging where they weren't before. And again, one of the last thoughts that I'd like to leave here is that of all the studies that are out, the clinical trials in children with autism, many of them from Israel, some from South America, all of them document the majority of patients have benefit. And I think when we're talking about harm reduction and we're talking about children's brains and we're talking about the difficulties associated with autism, especially severe autism, I think that we have to look at the data, and the data tells us that cannabis can work for these patients. And that in these studies, I bet you could even get better results if you customized for the children. But usually in the study, they pick one compound and that's what they give. And you would get better results if you actually customized. And so I just want to leave that final thought that to anybody out there who's considering cannabis, but kind of maybe living in fear that, am I really going to give my kid cannabis? Is it really a thing that I can do? What I would say is find a healthcare professional that can help you. Janna's trained a whole bunch of nurses. I try to train doctors. And we as the medical community who's knowledgeable about cannabis can help you sort it out. And again, whether it works or not, at least one of the things that I say is if it works, great, you have it as a tool in your toolbox. If it doesn't work, you can cross it off your list and move on to the next thing.
Anybody else have any other final thoughts? And that was such a great final thought. You actually segued exactly what I wanted to do. So thank you so much. Dr. Fisher, do you have any final thoughts?
That, no.
It's pretty hard one to top. Go ahead and take a stab at it, Janna.
As an autism parent myself, having experienced the profound benefits of autism for my child, it is definitely worth trying.
I mean, of cannabis.
All kinds of considerations around the cannabis and accessibility. And I'm thankful to be in a state where my child can access it legally and we don't have to worry about legal problems. But, it's worth trying, and I think when you assess the cannabis versus the pharmaceutical options, it's often the first logical choice to try for your child with autism. And I know as an autism parent, we would do anything to ease our children's existence and help them have better quality of life. And this is an option that has the ability to do that, as evidenced by many, many patient outcomes. And, one group I'm in is 30,000 parents of kids with autism treating their kid with cannabis. So it may seem like it's rare or that it's just not happening very much, but I can tell you, once parents learn about it and try it, boy, it can be life-changing. So I would just encourage you to research it. And like Dr. Bonni said, find somebody that can provide guidance and can assess your child's situation and help to put together a really solid protocol for them. And that'll save you a lot of trial and error. It may not be the end all be all, even with an educated guess, or you may need to experiment a little bit, but it's totally worth taking the time to do that.
I absolutely agree. And I would like to say, but my focus here with this podcast, with this panel, for at least one of them, is that I want us to come together as a community, and not just in the U.S. but worldwide. Because what I'm hearing from people around the world is it's still stuck in the dark ages in some places. I've heard, I don't know if this is true, but I've heard that France still puts people diagnosed with autism in insane asylums. So if that's true, that is just terrible, sickening. And when I heard it, it made me want to throw up. I can't imagine being thrown into an insane asylum with insane people just because of a deficiency in the endocannabinoid system. So that's one thing I want to push, is that our community should come together, the cannabis community, or at least the medical cannabis and the autistic communities, to come together and try to combat this in such a better way and a wonderful way. But that's my last thought. Thank you so much for joining me. I've just from this discussion alone, there's so many things I've got written down and ideas I have for the future that I'm going to be contacting you guys individually for. I really want to get into your guys' research. We are already at 2.5 hours, so I don't really think we really want to get into that right now, but I'd love to have you guys back if you want to get into that.
Sure.
I think that'd be really great. I really want to get into your books, and especially with Janna and her daughter. I think that a lot of people could benefit just to be able to dip their foot into the cannabis or medical cannabis pool. I just also want to do a really quick shout out to Megan Bang, trusted Canna nurse. She really went out of her way and got this panel together, and she's really helped me out, and I couldn't suggest her more. So definitely check her out in the description, and her products. Now, I hope everyone enjoyed. I hope that you definitely leave a comment and ask a question, because as I will now say, you don't have to ask a question well to ask a great question. So definitely ask your questions. And now, as always, Jay, it's going to go. Have a Jay.
Thank you.
Bye. Thank you.